Good morning. My name is Inderjit Singh. I'm an assistant professor at Yale School of Medicine. I'm in the Division of Pulmonary Critical Care and Sleep Medicine at Yale New Haven Hospital. Today, my topic is going to be on post-COVID dyspnea evaluation. Should you get a CPET or cardiopulmonary exercise test? So I have no financial disclosures. So the focus of my presentation will first be on the clinical phenotype of patients referred to our unexplained dyspnea clinic. I'll then move on to discuss a unique investigative study we perform here at Yale called an invasive cardiopulmonary exercise test. And I'll end my presentation discussing our experience using invasive CPET in the post-COVID patients and as well as in the non-COVID population as well. So let's get started with the first focus of the presentation. So we have a close working relationship with our comprehensive post-COVID center here at Yale, or what's called the recovery program. This is a multidisciplinary model that provides comprehensive evaluation of patients with post-COVID-19 complication. Incorporated within the recovery clinic model is a referral process for an invasive CPET evaluation with our group, the pulmonary vascular disease group, specifically for patients with unexplained dyspnea after having undergone comprehensive initial diagnostic evaluation as well as pulmonary rehab. So next, we're going to focus on the invasive cardiopulmonary exercise test that we offer here at Yale. So what is a level 3 or an invasive CPET? A level 1 CPET is what most are familiar with. It involves a stationary cycle ergometer along with a mouthpiece with a gas exchange analyzer connected to a metabolic cart, which allows for assessment of oxygen consumption and CO2 exhalation. A level 2 cardiopulmonary exercise test has the addition of a radial arterial line, which allows for ABG analysis during exercise. While a level 3 cardiopulmonary exercise test or an invasive CPET incorporates all three measures. So it has an non-invasive cardiopulmonary exercise test component with a cycle ergometer, a radial art line, and in addition, we place a pulmonary arterial catheter as well. So an individual's exercise capacity is the culmination of the dynamic interaction between the heart, its pulmonary circulation, and skeletal muscle. An invasive CPET allows for the comprehensive and dynamic assessment of the right ventricle, pulmonary vasculature, and skeletal muscle functioning during incremental exercise testing. The components of an invasive CPET includes the metabolic cart, which allows for VO2 measurement, a radial art line, which allows for ABG assessment. But in addition to these, there's also a 5-port right heart cath that's placed, which allows for continuous measurement of the right atrial, right ventricle, pulmonary arterial pressure, and every minute we get a wedge measurement as well. In addition to that, we draw a blood gas from the distal port, which allows to determine what the O2 content in venous blood is. So with these blood gas and hemodynamic data, you can then determine directly measured fixed cardiac output from the CaVO2 difference, stroke volume, and various different measures of right ventricular afterload, including the PVR and PA compliance. So I'm just going to show you a video of the invasive CPET setup we have here at Yale. The patients in this video agreed to have consented to have their test procedure being shown for educational purposes. So this is the setup we have right here. Back here is a monitor that's connected to the 5-port swan, which allows for continuous monitoring of your right atrial, right ventricular PA, and every minute we get a wedge and we draw blood from the A line and the pulmonary arterial catheter. So this patient's approaching peak exercise right here, and then the blood gas gets sent off to the lab for analysis, and then we collect the metabolic cart data up front as well. So in addition to doing the test upright, We also do it semi-recumbent, which allows for simultaneous echocardiography assessment as well. So this semi-recumbent bicycle is specifically designed such that it's tilted to the left. And so similarly, we get continuous PA monitoring, VBG analysis, ABG analysis. And here you can see we're getting simultaneous echocardiogram, specifically to look if there's dynamic worsening of valvular regurgitation, for example, accounting for their cardiopulmonary limitation. So this here represents a rough diagnostic flow algorithm that helps determine potential limitations imposed onto a patient's peak aerobic capacity using data obtained from an invasive CPET. So from the top, peak exercise aerobic capacity impairment is suggested initially by a peak VO2 that's less than 80% predicted. A central cardiac limit to exercise is suggested by a reduced peak cardiac output of less than 80% predicted, while a peripheral limit to exercise is suggested by a depressed peak VO2, along with a preserved peak cardiac output response and an impaired systemic O2 extraction. Systemic O2 extraction is defined by the difference in the CaO2 and the CVO2 divided by the CaO2. This, broadly speaking, there are three forms of central cardiac limit based on invasive hemodynamic data. So there's right heart disease, there's left heart disease, and there's preload failure. So preload failure is where an individual fails to appropriately augment their stress blood volume during exercise, with resultant reduced biventricular filling pressures. So move on. So next, we're going to discuss our post-COVID-19 experience with the invasive CPET. So there's a considerable overlap in clinical presentation between ME/CFS or myalgic encephalomyelitis / chronic fatigue syndrome and patients with post-COVID-19 syndrome. Those who are familiar with caring for patients with post-COVID-19 syndrome will be very familiar with these presenting symptoms. A lot of the long-haul COVID-19 patients exhibit symptoms that are consistent with ME/CFS, such as persistent fatigue, post-exertional malaise, unrefreshed sleep, plus minus cognitive impairment or orthostatic intolerance. In fact, a recent study by the group from Mount Sinai found that nearly half of patients with post-COVID-19 syndrome met clinical diagnostic criteria for ME/CFS. This is a study from one of our colleagues here at Yale who partnered with the folks at the Brigham, where they retrospectively reviewed 160 invasive CPET cases, all patients of whom actually met clinical criteria for ME/CFS. They found that patients with ME/CFS exhibited a primary peripheral limit to their peak aerobic capacity that is characterized by impaired systemic O2 extraction. They then further categorized these patients into two distinct pathophysiological phenotypes according to the degree of pulmonary blood flow. What they found was those with ME/CFS with higher pulmonary blood flow tend to have worse peak exercise aerobic capacity and worse systemic O2 extraction. So essentially, the greater the shunt peripherally, the greater the pulmonary blood flow, the worse the peak VO2 was, and the worse the systemic O2 extraction was. So let's move on to the CPET experience in post-COVID-19 patients, focusing first on non-invasive CPET. So the first study here is level 1 CPET performed in 75 patients 3 months after their hospital care. About half of patients had critical disease, with more than half having residual lung disease on CT chest. The authors concluded that deconditioning was the cause of the reduced peak exercise capacity, primarily because of early attainment of the anaerobic threshold, and also because many other measures of cardiopulmonary responses, including the ventilatory efficiency and O2 pulse, were normal. The second study, which was a larger study of 190 patients, also 3 months after hospital discharge, they included 20% of patients who had ICU level of care, and they observed about only 31% of patients had reduced peak exercise capacity. And these patients had normal measures of ventilatory efficiency and O2 pulse, which then led them to conclude that these patients were primarily deconditioned. This is a level 2 CPET study, so with echocardiogram, so upright cyclorgometer, radial A line, and then an echocardiogram. And they performed it in 18 COVID-19 patients the day of hospital discharge. They found that the reduction in peak VO2 in these patients was from a peripheral rather than a central cardiac limit. Notably, the COVID-19 patients were significantly more anemic than the controls. So if you look at the equation for systemic O2 extraction, where it's the difference between the CaVO2 divided by the CO2. Now the CO2, the CaO2, the arterial O2 content is highly contingent on the hemoglobin concentration. And so by being anemic, you're going to have a reduced not only DO2 or oxygen delivery, but also oxygen content in arterial blood, and therefore they will manifest as impaired systemic oxygen extraction. And so our group, along with the team from the Yale post-COVID recovery program, decided to examine the pathophysiology of unexplained dyspnea in post-COVID-19 patients using invasive CPET. These are patients who acquired mild COVID, only one of whom was hospitalized for 2 days, I think, and on average underwent ICPET 11 months after the acute illness. And keep in mind, these are patients who, prior to getting a CPET, underwent all the conventional investigative testing that were unremarkable or did not account for their symptoms. So CT chest, resting echo, resting right heart, Holters, lung function tests, and so on. And what we found was the objective decrement in the post-COVID-19 patients was not imposed by limitations of the heart-lung circulation, but rather a peripheral limitation characterized by impaired systemic O2 extraction. And so from these slides, now I include all the components of the Fick equation. So there's the VO2, cardiac index, and systemic O2 extraction to highlight which component is primarily responsible for the reduction in peak VO2. So you can see that in controls below here, their mean VO2 and the cardiac index exceeded their predicted values, and they had normal extraction. However, above the slide above, slide A, in the post-COVID-19 patients, while their cardiac index exceeded their predicted mean, the VO2 was depressed as a function of the reduced EO2 or O2 extraction. So in summary, we observed that the exercise limitation in these patients is a result of impaired peripheral O2 extraction and not from a central cardiopulmonary limitation imposed by the heart or lungs, meaning that they did not have any heart failure or pulmonary hypertension, either at rest or during exercise. Additionally, the post-COVID-19 patients also demonstrated an exaggerated hyperventilatory response during exercise, as evident by the increase in their VE/VCO2 or ventilatory efficiency in association with a decrease in the arterial CO2 content at the anaerobic threshold. Importantly, the increase in the VE/VCO2 was not associated with an appropriate decrease in dead space ventilation, because an abnormal dead space ventilation can also account for an abnormal VE/VCO2. Deconditioning is an unlikely explanation for the observations that we found, because a deconditioned individual will not mount a peak cardiac output of about 115% predicted. The counter argument is that they're deconditioned, and so the high cardiac output is a reflection of the high heart rate. But as you can see, that their heart rate response was similar to our controls. I also wanted to bring to your attention the trend towards a lower peak right atrial pressure in the post-COVID cohort versus controls here. This here is data that's yet to be published, but will be presented at the upcoming ATS meeting. So what we found was that preliminary, the post-COVID-19 patients have impaired augmentation of the stress blood volume. So total circulatory volume is made up of unstressed blood volume, which maintains vascular wall tension at rest, and stress blood volume, or the volume of blood that drives vascular pressure beyond that of the unstressed blood volume. So during exercise, venoconstriction mobilizes blood from the venous capacitance vessels, increasing the stress blood volume and causing a rise in the right atrial pressure. We calculated the estimated stress blood volume by incorporating measures of rest and exercise cardiac output, right atrial pressure, wedge pressure, as previously described by this equation. And what we found was, while there was no difference in the estimated stress blood volume at rest between the groups, in controls and post-COVID patients, but the post-COVID patients failed to appropriately augment their estimated stress blood volume during exercise, suggesting impaired venous capacitance function. Since the paper has been published, we've performed about 27 invasive CPET in the post-COVID-19 patients, and one had exercise PH and 2 patients had exercise HFpEF. The remainder of patients have a primary peripheral limit to exercise intolerance. And keep in mind, these are patients who've had unremarkable conventional investigative studies. So before I end, I wanted to briefly go over other diagnostic utility of the invasive CPET, specifically some of the work our group has done recently. So there are other diagnostic utility of invasive CPET. For example, it allows for dynamic assessment of the RV and its pulmonary circulation. It allows to unmask early disease, and the hemodynamic markers obtained can serve as potential endpoints for clinical trials or studies that investigate drugs to restore or augment contractile reserve. Current therapies for pulmonary hypertension aim to limit progression and complication, but are not curative. So for this Kaplan-Meier curve right here represent mortality from time of diagnosis in patients with different forms of PH. The blue curve represents patients with PAH, and the mortality is 40% in 5 years. This is despite our advancement in PH therapy and despite our increased knowledge in PH pathophysiology. The reason for this in large part is because of delayed recognition of the disease and therefore perhaps delayed institution of treatment. Often treatment institution occurs at a time where patients present with advanced RV failure. So our group has studied the implications of dynamic interaction between the RV and its pulmonary circulation during exercise in various forms of pulmonary hypertension. In particular, we've studied dynamic exercise right ventricular pulmonary arterial coupling, which refers to the ratio of RV contraction to its afterload. And so preservation of the RV-PA coupling ratio indicates that indicates maintenance of RV functioning in the face of increasing afterload. We also looked at the interaction of the RV and its pulmonary circulation in PH between the sexes and different forms of pulmonary hypertension during different phases of incremental exercise testing. For example, this is one study. We looked at RV-PA coupling during exercise in our PAH and exercise PH cohort. The exercise PH patients are patients with normal resting hemodynamics who go on to develop abnormal cardiopulmonary hemodynamic response during exercise. So from this first slide, while the exercise PH patients are able to augment its contractility from rest to peak, so blue bar graph to red bar graph, the insurmountable increase in the RV afterload, or EA, culminates in RV-PA uncoupling. That's slide C, and that which translates into worse right ventricular function at peak exercise. This, similar to patients with resting PAH, although to a lesser degree, was associated with a blunted stroke volume index and peak exercise capacity response as well. Using invasive CPET, we've also studied a novel and early marker for pulmonary vascular disease. So everyone's familiar with the PVR equation, which is the ratio of the TPR to the cardiac output. if you rearrange this equation, your mean pulmonary arterial pressure should increase linearly as your cardiac output increases. Instead, the mean PA to cardiac output relationship has a curvilinear relationship, suggesting that an increase in mean pulmonary arterial pressure is attenuated at higher cardiac outputs. That's because there's a fourth variable, which is the pulmonary vascular distensibility, that attenuates the linear increase in mean pulmonary arterial pressure as the cardiac output increases. Without going into too much detail, this is the equation that we use to calculate alpha, or pulmonary vascular distensibility, during incremental exercise. It involves the input of various pressure and flow measures during exercise, and alpha is defined as the percent change in vessel diameter for a given transmural pressure change. And alpha at constant hematocrit was then determined by non-linear squares fitting of the equation right here. We showed that alpha, or pulmonary vascular distensibility, was the most sensitive hemodynamic marker to detect pulmonary vascular dysfunction compared to more conventional measures, including rest, PVR, peak PVR, rest compliance, peak compliance. We also showed that alpha can be used as a marker of disease progression. As you can see in the second slide here on the right, alpha values decrease as you have a disease process with more significant involvement of the pulmonary vasculature. So in summary, invasive CPET provides comprehensive assessment of the dynamic interaction between the RV, pulmonary circulation, and skeletal muscle. Invasive CPET represents an important investigative study in patients with unexplained exercise intolerance. There is considerable overlap in the clinical presentation between MECFS and our post-COVID patients. Invasive CPET should be considered in post-COVID-19 patients who have unexplained dyspnea by conventional investigative means. Impaired systemic O2 extraction, exercise hyperventilation, and impaired stress blood volume augmentation all contribute to exertional intolerance in post-COVID-19 patients. The pathobiology that underlies the peripheral limit to exercise in post-COVID-19 patients does require further understanding. Exercise hemodynamics have the potential to unmask early pulmonary vascular disease, and dynamic RVPA uncoupling and reduced distensibility can serve as early hemodynamic markers for right ventricular and pulmonary vascular dysfunction. So all the work that I just presented would not be possible without the many collaborators I've had across different institutions, including at the Brigham, here at Yale, and elsewhere as well internationally. This is the invasive CPET and the PH team at Yale, and this is Yale, and I'm happy to take questions now.